Well, hello there everybody, and welcome to Ovarian Cancer Australia's first webcast. My name's Anne-Marie Ferguson and I'm one of the coordinators of the support programme with Ovarian Cancer Australia. Before we begin this evening, I'd like to acknowledge the traditional owners of the land that we're standing on, the people of the Greater Kulin Nation, and I pay my respects to them, elders past and present. I would also like to acknowledge the Roche Foundation for funding this project. Today's webinar is on the theme of PARP inhibitors and ovarian cancer. The webinar is interactive, so please, I encourage you over the next hour to ask questions of the presenters. You'll be able to do that by typing into the chat box, which is located at the left-hand side of your screen. We're very eager to hear your questions. Your questions will be answered at the end of each presenter's speech. Please keep in mind that our presenters cannot address individual medical cases. If you have particular questions, you can call the Ovarian Cancer Australia support and information line. Also, if you're experiencing difficulty hearing the sound during the webinar, please dial the 1-800 number listed on the chat box. All right, so today we are very pleased to, welcome our presenters. Kristen Young is an ambassador for Ovarian Cancer Australia. Kristen was diagnosed with stage 3C ovarian cancer in 2009. After surgery and chemotherapy, she started her first clinical trial for maintenance with an anti-angiogenesis agent. She was also found to have the BRCA 2 gene fault, and after a good remission, she relapsed in 2014, and after more surgery and chemotherapy, she started on the PARP inhibitor Olaparib clinical trial, which she is on to this day. Jonathan Lederman, Professor Jonathan Lederman of Medical Oncology at UCL Cancer Institute and a consultant in medical oncology at UCL hospitals, works in the Gynecological Cancer Centre. He's the clinical director of the UCL Cancer Institute and director of the Cancer Research UK and UCL Cancer Trial Centre, which is one of the national trials centres in the UK. Well, without further ado, I would like to pass us on to Professor Lederman to give his presentation this evening.
Thank you very much, Anne-Marie. It's a pleasure to be here in Australia, and I feel very honoured not only to have been invited to give this talk for Ovarian Cancer Australia, but actually to participate in the first webcast that you've done. So thank you for that. This is a picture of University College London, where I work. So what I'd like to do this evening is just to go over a little bit of the background of the poor prognosis that we have with current treatments of advanced ovarian cancer, and then talk a little bit about PARP inhibitors, the topic of tonight, and how these PARP inhibitors have developed and link their action to patients who carry this BRCA gene fault, and why this class of drugs is so active in women who have this BRCA gene fault. And then to discuss the results of the clinical trials that we had with PARP inhibitors that have led now to a new licensed treatment option for women with recurrent ovarian cancer. And then lastly, just to look a little bit into the future as to how these PARP inhibitors, I think, are going to develop further and give us greater opportunities for the treatment of ovarian cancer. So recurrent ovarian cancer is something that unfortunately most women with advanced ovarian cancer will experience at some time after they've had surgery and first-line chemotherapy. Now, many of these women will have a very good response to further treatments, but these are often of short duration. Chemotherapy has been the backbone of treatment for many years, but we give the same drugs to all patients without tailoring any of the treatments to the particular biological behavior of the tumor. And what we also know is with successive treatments, it becomes harder and harder to keep the disease under control. The responses become shorter as the tumors become more resistant to chemotherapy. So if we look at this schematically in a patient with recurrent ovarian cancer, and here I've listed the term platinum sensitive, which is what we use when the recurrence has occurred after an interval of more than 6 months. And these women will go on to chemotherapy for about 4.5 to 6 months, often have a very good response. And then we'll have a period of observation off treatment as they recover from the side effects of treatment and get back to normal life. But if you add these two sections together, it comes to about 8 to 10 months. And that's the average length of time before the next line of treatment is needed. And as time goes on, the tumors become more resistant to platinum chemotherapy. And although the treatment period remains reasonably constant, the time off treatment, the observation time, if you like, becomes shorter and shorter. So what we need to do is to try and lengthen these gaps between treatments, to lengthen these observation periods. And we need new treatments to do that. And those treatments need to be well tolerated so that patients' quality of life is maintained. And we need to develop these drugs that are specifically targeting patients who are most likely to benefit, not give them to all women in the hope that some will benefit. And that's what we call personalized medicine. So here you can see schematically lots of different patients, all colored differently. But only a few of those patients have a certain type of disease that will respond to a certain type of therapy, shown here in blue. So that's what we want to do. We want to pick out those women who are most likely to benefit from a drug, here a PARP inhibitor, and be able to give them that drug. So personalized medicine is using the right treatment at the right patient at the right time and the right dose, and that's what we've got to aim for. So if we look at PARP inhibitors, what are they? This is a sketch of our DNA, and all the time as we're sitting around this computer, we're getting breaks in our DNA, and you can see that schematically at the top of this cartoon. And that break is recognized by an enzyme, a chemical called PARP, and that binds to that break in the DNA and recruits in a number of other proteins that repair the damage and allow the DNA to become normal again and continue functioning and replicate. So what PARP inhibitors do is to inhibit that process, so that repair can't take place. So if you look at the bottom, you'll see again a little schema of the DNA. And PARP inhibitors work on these single-strand breaks of DNA. Now these normally are repaired unless you inhibit PARP. But what happens when you inhibit PARP is that you get these double-strand breaks of DNA, shown here with the 2 red circles. Now you can imagine these double strands are more serious because you've got to repair both ends to restore the DNA again. And this repair process takes place by a process called recombination repair. So if you block the PARP enzyme, you get the double-strand break that then is repaired by recombination therapy. But in women who have the gene fault in a BRCA protein, they can't produce the normal BRCA protein because they've got a fault in the gene, that recombination repair process can't work. And that's very serious for the cell because it can't repair itself and replicate, and so the cell here, the tumor cell, will die. So this is looking at it schematically. Look at the top. This is a normal tissue with a normal BRCA function. And the table legs here, there's one table leg that has the base excision repair, which is by PARP, and the other leg has this HR, homologous recombination repair, when you inhibit the PARP. So if you inhibit the PARP, you break one leg. But the table stands up because it's got the normal homologous recombination repair, and the table is stable. But at the lower graphs, lower section of the slide, you'll see that where you've already got damage to the repair process because of the BRCA deficiency, if you then block the base excision repair, the second leg breaks and the table falls, and that's tumor killing. So that's basically how PARP inhibitors work on tumor cells. And about 10 or 11 years ago, the first clinical trials started with a drug called Olaparib in patients with BRCA mutated tumors. Many of these women had ovarian, some had breast cancer, and there were some men too who had prostate cancer and a BRCA mutation. What was remarkable about these studies was that 63%, almost 2/3 of these patients, had benefit from these early trials with Olaparib. And what was also very interesting about these trials was that you can see in this graph at the bottom that the length of time, here the number of weeks, that patients remained well or responsive to these drugs was quite considerable. More than a year, more than 50 weeks in some of these patients. And these were patients who'd had lots and lots of treatment for their tumors. So it was immediately clear that this drug, Olaparib, was active in patients with a BRCA mutation. And here on the right, you can see a CT scan showing the benefit in terms of the radiology in the two patients who had this drug Olaparib for about 2 or 3 months. So within that period of time, these circled areas here, it's this tumor, you can see these getting smaller on Olaparib. But we know that drugs like Olaparib benefit more patients than just those with a BRCA mutation. Because we know that this homologous recombination repair deficiency that I mentioned earlier is present perhaps in up to half the women with high-grade ovarian cancers. Now we know that the mutated gene, the faulty gene, is inherited in about 14% of women who have high-grade ovarian cancer. And another 6% of women don't inherit a fault of the gene, but they develop the fault within the tumor itself. So that leaves 20%. But we also know that there are another 30% of women who also have a tumor that has all the features of this homologous recombination deficiency. And when Olaparib was tested in a wider group of patients with ovarian cancer, including women who did not have a BRCA mutation, we saw that the drug was active not only in patients with a BRCA mutation, but also in patients without a BRCA mutation. And you can see that here, the individual patients in each of these bars, and the ones in pink are the women who responded to Olaparib, but did not have a BRCA gene fault. And on the left-hand side were a few patients who did not benefit at all. But most of these women responded, and many of these women did not have a BRCA mutation. So that's what led us to the trial, which has become known as Study 19, where we gave Olaparib as maintenance therapy to patients with recurrent, high-grade, serous ovarian cancer that was responding to platinum. So in the trial, what we wanted to do was to look at what effect Olaparib had on extending this period after chemotherapy that I showed you earlier on, so that women might have a longer period off treatment before the disease recurred and before they needed more chemotherapy. So 265 patients were entered into this trial across 16 countries in the world. And I'm now going to show you the results of that trial. They were randomized either to maintenance Olaparib or a dummy tablet, a placebo tablet, and the measurements were made until the disease came back, and then the patients came off the trial. So what that showed was, on the left-hand side, this is what we call a survival curve. This is the time to disease progression. And those on Olaparib had a much delayed time to progression compared to those on the placebo treatment. And you can see that separation of the curves represents the benefit, if you like, of giving that drug. And the extension here, a 3.6-month extension, additional time off treatment before the disease progressed. Now, in this trial, we had patients with a BRCA mutation, and we also had patients that did not have a BRCA mutation, as I showed you in that previous study. But what we did is look more closely at the women who had a BRCA mutation, and we saw an even bigger effect of Olaparib in women that carried the BRCA gene fault. And here we can see that difference going from 4.3 months on average before the disease came back to 11.2 months. So that was a highly statistically significant difference. Recently, we've looked at the survival, the overall survival of these patients. We've been able to follow them up for many years, many more years, and we can see that there are trends in the improvement in survival in those patients taking Olaparib. Here on the right-hand side, you can see that's an even greater difference in women who have this BRCA gene fault. And what also is strange about these survival curves is where I've shown this arrow, it seems to flatten off. So after about 3 years, the curve seems to flatten off. And I'm going to come back to that in a minute because I want to explain that in a little more detail. So what we now have is 6 years of follow-up of this trial. So the last patients went into this trial in 2010. And what we're seeing is that now 6 years later, there are still 11% of women who are receiving Olaparib from this trial. 8 of these women have the BRCA mutation, but 7 of these women do not have a BRCA mutation. And there's 1 woman still receiving placebo tablets without any disease progression, but she has a BRCA mutation. So if we look at it on this bar chart below, these are the number of years that the patients on the trial have so far been on Olaparib. And we take this point here of 5 or more years, you can see that overall 13% of the patients in this trial continue on Olaparib without any evidence of recurrence of their disease 5 or more years later. And if we look at the patients who've got this gene fault, the BRCA gene fault, we can see it's 15%. So 15% of our patients with the BRCA gene fault are still taking the drug more than 5 years out with no recurrence of their tumor. And about 12% of the women who did not have a BRCA mutation, again, are taking this drug long term. And that's a really big new development for the treatment of recurrent ovarian cancer. And I'm just going to summarize those results schematically here. We measure this progression-free survival. That was our key differentiating measure, and as I showed you earlier, that's a 6.9-month difference and a small difference in the long-term survival in these patients. But I'd like to also draw your attention to something else that we looked at, which was not the time to progression, but the time before women had to start their next line of chemotherapy. And you can see that with Olaparib, there was a 9.4-month extension in the time before the next line of chemotherapy was started. So these women were, on average, avoiding chemotherapy for an extra 9.4 months if they took Olaparib. And we've very recently seen the results of a different PARP inhibitor studied in a very similar way. This is a drug called Olaparib, which is not yet available in the sense that it's not got a license. And we see virtually the same results here in those women with a gene fault, the BRCA germline inherited gene fault, very big difference in the time to disease progression. And even those that don't have an inherited BRCA mutation, we see differences in favor of Olaparib. So how well are these PARP inhibitors tolerated? Because if you're going to give a drug for a long period of time, it's important that women are able to manage this without too many side effects. So let's look in a moment at the key side effects of these drugs and talk a little bit about why we might need to modify the dose because of the key side effects, and to find out how many women discontinue the drug due to side effects. So these are all important considerations in assessing how well drugs are tolerated by women, and importantly, what is the quality of life on maintenance therapy. So we've looked at these things in considerable detail and really have been very pleased that the side effect profile has not been too severe. It's certainly nothing like chemotherapy. So for Olaparib, the main side effects have been fatigue, nausea, and anemia, but they are generally of mild intensity. And the nausea is often short-lived and can be managed by interrupting the drugs for a couple of weeks and then starting the patients again. Sometimes you have to reduce the dose for side effects. About a quarter of patients in the trial needed a reduction in the dose of Olaparib, but were able then to continue sometimes for several years. And only 6% of the women stopped the treatment early because of side effects. The Olaparib drug, which is, as I said, not yet available, I'm sure will be licensed relatively soon. Again, fatigue is an issue. They have slightly different side effects. The blood platelet counts and white blood cell counts can go low, a little bit like on chemotherapy, and they can also get anemia, and some patients experience a raised blood pressure. But this low blood count often is early in the treatment, unlike chemotherapy where it often gets worse as the treatment goes on. And some patients will then need a reduction in the dose or occasionally stop, but most continue. And again, only 14% of these patients actually dropped out of the trial because of side effects. So the BRCA mutation here is key. And what we know is, of course, that in women who have a significant family history of breast and ovarian cancer, there's quite a high likelihood that they might carry the faulty gene. But we also know that many women who have tested positive when groups of women have been evaluated give no family history of breast or ovarian cancer. For example, the gene may have been passed through the father's line, and therefore no breast or ovarian cancer may have been seen. So about a third of women who are positive for a BRCA mutation give no family history. And that's very important for all of us, because what it means is that we need to test for a BRCA mutation even if there's no family history of breast or ovarian cancer. And so in England, where I work, we will now offer testing to all women who are diagnosed with ovarian cancer. We also know that in about 5 or 6%, the gene fault lies within the tumor, but not inherited. We call this somatic or tumor mutation. And that's important because the drug is as active in those patients as it is in those who have an inherited form of the cancer. The difficulty is that testing at the moment is quite complicated. Testing the tumors is quite complicated and expensive, and it's not routinely available. But it's something we have to think about as physicians and negotiate with those that pay for healthcare and discuss this issue with our patients. So just to draw to a conclusion, these PARP inhibitors have given us a new treatment for ovarian cancer as maintenance after platinum chemotherapy for patients with a faulty BRCA gene, a BRCA mutation. And we now have a license, and the license has recently been granted in Australia for Olaparib. We see similar results with Niraparib, but we're awaiting the full license of this drug. And we note that both these drugs also have an effect on patients who do not have the gene fault, sometimes called BRCA wild type, normal BRCA genes. At the moment, the license is not available for those patients, but it tells us that we do need to do more studies to try and extend the use of these drugs as much as we can. There are 2 more PARP inhibitors undergoing trials at the moment that are looking at a wider group of patients, and there are also clinical trials going on exploring the combination of PARP inhibitors with anti-angiogenic drugs, those drugs that inhibit the formation of new blood vessels that tumors need to grow. So all those trials are in progress, as indeed are trials with PARP inhibitors and the immunotherapy, the immune checkpoint inhibitors. So there's a lot of work going on at the moment to try and extend the treatment with PARP inhibitors. So to summarize, finally, PARP inhibitors are a new class of drug for the treatment of recurrent ovarian cancer, and the first group to have had a major impact on the disease for more than a decade. They're generally well tolerated and can be given for quite a prolonged period of time. And there are now opportunities to extend further and expand the use of PARP inhibitors as these new trials that I mentioned just now, the results of these new trials become available. Thank you very much.
That is just fantastic information, really clear. I very much appreciate it, Jonathan. Now, when we opened up for registration for this webcast, we invited participants to provide some questions. So if you don't mind, Jonathan, I'll pose a few questions to you that have come in during the registration process. The first question is, can PARP inhibitors be given a second time after being effective for 11 months?
So that's a very good and important question, and one I have to say at the moment that we don't know the answer to. So we do very much need to look at the possibility of retreating a patient with a PARP inhibitor at a later time after the first PARP inhibitor has been given. There are a number of different PARP inhibitors undergoing trials, and what we may find is that changing to a different PARP inhibitor may give a second response. But at the moment, I think we can't say for sure whether a patient will again respond to retreatment with a PARP inhibitor.
Thank you. Next question is, does PARP cause mutation of cancer cells and contribute to the chemo resistance of cancer cells?
Gosh, these are very very good questions. The answer is probably yes, but we don't know how much that's affecting further responses to treatment. So we do know that women who have a PARP inhibitor, in whom the PARP inhibitor works for a number of months or even years, who eventually then have a regrowth of their disease and go back onto chemotherapy. We know that many of those women will again respond to chemotherapy. But I think there is a question mark over the length of that response. And I think that we need to follow up these women for much longer to learn more about how PARP resistance, if you like, may affect the resistance to chemotherapy. So to answer the first part of your question, do the PARP inhibitors cause further mutations? They may do, but I think in the end what we need to look at is the overall benefit of a PARP inhibitor. So going back to my very early slide showing you this really short period, relatively short period of freedom from further treatment, by extending that significantly, we actually extend the survival of women overall, and of course that's what we really want to do.
Fantastic. All right. Next question coming your way, and it might be located within the Australian context, is how many women in Australia are currently taking Olaparib?
I can't.
Yes,
thank you. I don't really think I can really answer that question. I think what I do know from the few days that I've been here is that there is an expanded access program, and I think that women in Australia are able to access the drug through that program. And at the moment, as far as I'm aware, there's not general reimbursement for the drug, but that's being considered at the moment.
Indeed it is. That was a question from Gail. Hello, Gail. Please feel free to give Ovarian Cancer Australia a call, and we'll do our best to come up with some information around that for you. Next question. I'm currently receiving Olaparib compassionately. Will this continue again? Jonathan, this might be out of your scope because it's Australia.
From what I understand, from the little time I've been here and talking to colleagues, I think that when patients are on the expanded access program, they will continue to have it until the health payers in this country agree to pay for it, in which case I guess patients will then transfer over to that. So I don't think there's any danger that patients on this program will come off the drug purely for financial or administrative reasons. It will only come off if it's not working or if they have side effects that can't be easily managed.
Thank you. A question, if I have already had failure on Olaparib and I'm BRCA2 positive, what does this mean with other PARPs? Will they also fail?
Well, we don't know as to whether or not re-challenge with different PARP inhibitors is going to be effective in this situation. At the moment, Olaparib is the only licensed one, and if that's the drug that you've had, then it will be difficult to access another PARP inhibitor unless it's a clinical trial that's specifically looking at retreatment of patients. So those trials are beginning. I don't know whether they're open here in Australia. They're just beginning. Perhaps not on their own, but in combination with other new drugs. So I think it's worth just keeping a lookout to see if those trials are available.
That's a really good segue into the next question, which asks is it possible to join a clinical trial from another country?
That is generally quite difficult, and we've had this even within Europe, where patients, have tried to sort of move from one provider to another. It's not impossible, but it is quite difficult. These trials require often very frequent hospital visits, and those visits have to be in the hospital where the trial is taking place. So that means effectively being in that country for a long period of time, and that can be quite a difficult thing to do. So generally speaking, the answer is no.
Question asks is about the suitability for women without the fault in the BRCA mutation, without the fault in the BRCA.
Yes. So at the moment, the license and therefore the expanded access program covers only women who have the gene fault. But we know from the clinical trial that some women without that gene fault had a very good effect from the drug. So I think we really need to some women without that gene fault had a very good effect from the drug. So I think we really need to get into greater detail of understanding that so that we can, I hope, expand the opportunities to use these drugs in those women without the gene fault. So I showed you the results of the Olaparib trial, which included women without the gene fault. There's the other ongoing trial with recurrent, another PARP inhibitor. So I think if these come together and they consistently show that a certain proportion of women without the gene fault benefit, then I think there's a hope that we can see the drug licensed in a broader group of women so that it's more freely available to them.
Two more questions, Jonathan. What's coming in the future? Options to Olaparib?
So I think the next big step is going to be combining Olaparib or PARP inhibitors, but here Olaparib, with other drugs. And here I just will make a little plug for an international trial that will open in Australia. It's called the ICON-9 trial that we're running from the UK, but in collaboration with ANSCOG. And that will combine Olaparib with an oral tablet called cediranib, which is a drug that inhibits the growth of tumor blood vessels. So actually, by joining that trial, all patients will get Olaparib, even without gene fault, and half of them will in addition get maintenance of cediranib. So we're hoping that trial will open in the second or third quarter of next year.
Well, as you can imagine, the Ovarian Cancer Australia support line is going to be inundated with telephone calls asking for more information about that. So I would just like to reassure people that we will get further information from Professor Lederman and make that available to everyone. Our final question, which will segue into our next guest speaker. The question asks, is there a way to reduce the fatigue caused by Olaparib? And what is the minimum effective dose of Olaparib?
These are both very, very good questions. Fatigue, of course, is a very variable symptom. For some people, for some patients, fatigue can be debilitating. For others, it's just a bit of a nuisance. And so we see this spectrum with Olaparib too. It seems that in many women, the fatigue comes in the first 2 to 3 months and then fades spontaneously, or we just give a patient a break for 2 weeks and then restart treatment and they seem to continue without the fatigue. Occasionally, we reduce the dose of the drug and then they can continue without the fatigue. So what effect then does, which was the second part of your question, does reducing the dose have on the treatment? The dose that we use is what's called a flat dose. It's the same dose for all women, different sizes, ages, no consideration at all for the way in which we all metabolize our drugs, which is differently. So for some women, the dose of 400 twice daily is too much. And by reducing it to 200, their body not only copes better with it, but it has an effect on the tumor, which, as far as we can tell, is as good as those women taking the higher dose. So we don't seem to compromise effectiveness by reducing the dose in those women that need a dose reduction. That's not to say that everybody should have a dose reduction, because some women may need a higher dose because they break down the drug more quickly. So I think what we should be aware of is tailoring the treatment to the symptoms, and where we can't manage the symptoms, or a patient can't manage the symptoms by having this pause in treatment, then the next step is to reduce the dose. But going back to the trial, only 6% of the women stopped treatment because of side effects. So most of the women, either with dose interruptions or dose reductions, can continue the treatment. And as you saw, about 15% of the women with a BRCA gene fault were taking the drug for more than 5 years continuously.
Thank you so very much. I'm sure I'm speaking on behalf of many of the women who are listening today, Jonathan, that your information, the women are greedy for this information, and I really appreciate you taking the time to do it. Now, my next pleasure is to introduce our next guest speaker. That's Kristen Young. Kristen, that's over to you.
Thanks, Anne-Marie. This is Kristen. I have stage 3C ovarian cancer, which is now recurrent, and I'm speaking today because I'm on an Olaparib trial, and we'll talk about my experience. And initially I'll just talk about my experience of having ovarian cancer and the treatment, and I'll talk about what I think and what I feel about being on Olaparib and on a PARP inhibitor and what that means to me and how that affects my life. So I was diagnosed in 2009. My pathway to diagnosis was a bit unusual, but I guess everyone's is a bit unusual because the symptoms are so vague. But I started with unusually large lymph nodes in my groin, but I didn't have some of the other symptoms of bloating and those sort of things. So I ended up having a biopsy of those lymph nodes, and they, to everyone's surprise, found a tumour that was clearly gynecological. But the funny thing about that is that I'd actually had the ultrasound that's recommended for ovarian cancer, and they didn't find anything. So I think my tumour was hiding. So I guess the takeaway lesson from that is that it can be a really unpredictable and variable pathway to getting your diagnosis. But for all that it was an unusual pathway, I had a very standard form of ovarian cancer. So I had the standard initial surgery and initial chemotherapy. It was the 18 weeks, and that just went along in like a pretty predictable way. It was difficult, but nothing unusual happened. And this is a picture of me after surgery. So I'd like to put that in so I can remember that it's not like that anymore, and you can just forget those bad times, but also to remember what it takes to go through this thing as well. So that's during my first chemotherapy, just after I'd had my head shaved, and then all those last stubbly bits then eventually fell out. You can see I'm quite pink-cheeked from my dexamethasone I've actually had a memory blank of what the drug is that you take to prevent the allergic reactions. Anyway, that's how I looked for about 6 months. But when I finally, finished chemo, I was thinking the whole what now that we all think about, what's going to happen to me. And I'd read about things a bit, and my oncologist at the time referred me to a clinical trial. And I liked the idea of that a lot because I thought I may get some medical benefit from it, but for me, the thing that mattered to me most is I was going to get plenty of attention. So I was going to get doctors paying attention to me, checking how I was going. And I wasn't going to sort of suddenly be lost in the wilderness and wonder, what's going to happen to me. So I thought going on a clinical trial would sort of let me down easy. And if I benefited from it medically, then that would be great too. So it was really good. I was on a angiogenesis inhibitor, and which is Dr. Lederman said is to prevent the growth of blood vessels in tumours. Though I could have been on the placebo, and to this day I don't know whether I was on the placebo or not, but it didn't matter. That wasn't the main reason I was on the trial. But it helped me to gradually get back to normal life, and I knew enough about the statistics to know that a significant proportion of people in my situation were going to have a relapse, but years went on and on and on, and I still didn't relapse. So I began gradually to, get back to really a pretty normal life. It never completely goes out of your mind, of course, as anyone with ovarian cancer would well know. This picture is me doing some advocacy for Ovarian Cancer Australia at an afternoon teal at a ladies' golf day. But the way I sort of coped with it was by making sure I had plenty of information and treating it almost like a job for myself. So making sure I surrounded myself with a good team, the team being not only friends and family, but people who could look after my health, like obviously good doctors, but things like being a massage therapist, a physiotherapist, someone to help me with the risk of lymphedema, psychology, support groups, physical exercise, and all of those sort of things. But it was always the possibility of the relapse from around the corner. Now, when I was on the first clinical trial, I was not eligible for a PARP trial because at that time there were no PARP inhibitor clinical trials going on for women who hadn't had a recurrence. So ironically, I was thinking, you know, if I'd already had a recurrence, I would be able to get this wonderful PARP inhibitor drug, but I haven't. I have to wait my first relapse before I get access to this great new drug on a trial. But after 4.5 years of remission, then I had a relapse, which was wasn't very obvious at first. It took a while to diagnose because a lot of it was in my lymph nodes. A lot of those lymph nodes were very high up high in my abdomen, up under my diaphragm, and certainly you couldn't feel them from the outside. And they also didn't cause a very big increase in my CA125. But the very first thing I talked to my oncologist about is, when we finished treatment for this relapse, going on a PARP inhibitor trial. So my day had come. So back into more surgery, and this time it was a difficult surgery, just mainly because I had some side effects from the surgery that I hadn't expected. A leak of lymphatic fluid into my abdomen that was swelled it all up for about 2 or 3 months. But once I settled down from that, I started a second round of chemo. Now this is where it got interesting, because I knew at that time that the PARP inhibitor trial that I wanted to go on had a closing date about 3 or 4 months down the track. But it required that I had done 4 cycles of chemotherapy to make me eligible to go on the trial. Initially, I was too sick to start the chemo, so I was negotiating with my doctor to try and get started on my chemo so I could count out the number of chemo sessions I had to get done to meet the criteria for the trial so I could get on the PARP inhibitor. So there was this race against time to complete the minimum requirements. And the funny part about that is, towards the end of the chemo, as I was going through the suitability to get on the PARP inhibitor trial, is they had a minimum hemoglobin level I had to get, and because I'd been really unwell after the surgery, the hemoglobin was low. So I started thinking up desperate ways to meet the minimum cutoff for the hemoglobin. So I'd come in for my test. I don't know if I should say this, but I came in for my test, and I'd make sure I really dehydrated before I went in, because I'd heard from a doctor friend that would make your hemoglobin level higher. I was eating large, rare steaks for a couple of days before, hoping, probably not correctly, that would increase my hemoglobin. But anyway, I finally got on to the trial, and then I felt how lucky I was, because this is what I'd wanted really from the beginning. So, and I think it's because, as someone with BRCA, it was something that enabled me to have a greater opportunity than what was available to me if I didn't, and that was just to wait, and to wait basically for my next relapse and not to do very much. So, life on the PARP inhibitor. It is a placebo trial, but I believe, and my doctors believe, that I'm actually on the active drug, and we believe that because of my side effect profile. And as Dr. Lederman was saying, one of the main side effects for me is fatigue. Difficulty is knowing, how much of the fatigue is due to the Olaparib, and how much of it is to do with, being postmenopausal now, or to do with just general post-cancer fatigue and aging. A couple of times now we've worked out that I have a 2-week drug holiday to see whether it makes any difference, or I think an interruption is what Dr. Lederman was calling it. And I know that it certainly goes, if I'm off it for 2 weeks, I do feel like I have more energy. So I do attribute a chunk of the fatigue to the effect of the drug. So there are a few other minor side effects that are less troubling than the fatigue, and that includes mild nausea. This just a photo of me recently wearing my teal for an ovarian cancer function that I was on my way to. So mild nausea, which I only ever needed to manage with, basics of taking Stematol, and doesn't affect me very much at all, but it's definitely there. The other one is a suppression of appetite, like losing interest in food, which I consider to be a good thing in some ways, because it helps me to eat more healthily and manage my weight, and so I'm trying to capitalise on that a bit. But a few other minor things like mouth sores, and I also get really funny dreams, which a few people on PARP inhibitors apparently report as well. So, but it has led for me to make lifestyle changes. I've now formally gone down to working part-time. And this is a photo of us recently, just a couple of weeks ago, at the Ovarian Cancer Australia 15th birthday celebrations at New South Wales Government House, and that's us with the Governor of New South Wales. So, and this leads into the fact that I think one of the things that I can do with my cancer experience is to try and send a bit of a message to other people about living with cancer in a way that gives you a degree of still having a reasonable quality of life. And one of the things I've also done is to assist Ovarian Cancer Australia with some of the advocacy to trying to get Olaparib put on the Pharmaceutical Benefits Scheme, or the PBS, so that it's a subsidised drug for everybody to use, all those that are eligible for it. So living every day on a clinical trial on Olaparib, this is a photo of my last holiday when I was walking in Switzerland. And that was actually the day after, the first day of my drug holiday. I was actually really sick that day because I believed I was withdrawing from the drug. But when I got to the top of the hill, I had a beautiful view, so I felt better. But anyway, twice a day I take my two tablets, and I had set my alarm, so my daily routine is driven by 7:30 a.m. I have to be up for my drugs, and 7:30 p.m. and you have to take them with food, so I've got to organise all my meals around that. But that's a whole question, is this worth it? I believe, and I think the evidence is developing, that this does make a difference to your survival. And this is living with the side effects of it, and living with some restrictions on my life that come with that. I think I'm calculating that is worth that for me. Because then I think, what would have happened? How would it have been if I hadn't got onto the trial? So this is a picture of my dad. We got the BRCA gene mutation came down through my dad's line, and he passed away from prostate cancer in 2003. So one of the things is if Olaparib doesn't extend your overall life, it does, I feel, improve your quality of life. So even if it isn't a cure, what seems to be important for me and for other people is that living your life now, when you're working, travelling, and fulfilling your responsibilities, it seems to be able to increase that quality of life. But what about the people? Oh, this is my family, and this is one of the last sort of things that Dad did. He paid for my 40th birthday party not long before he died. But is it? I feel like I'm lucky, and because I'm BRCA and because of circumstances that I have access to Olaparib. But there are a lot of people who don't have access, either because they're not BRCA or they're unable to get onto the compassionate access program, or they missed out on a trial. And sometimes I feel a little bit, a little bit guilty that I've had that access and other people haven't. At the same time, though, I know that people feel there's a sense of hope to see that even if there's a new treatment that doesn't benefit them, that they're glad to see that there are new ideas out there and that the medical profession is working to find solutions that may eventually benefit even more people. So there is a sense in which, even though a relatively small number of people benefit from this drug at the moment, it does represent a new way of thinking and a sense of hope for people going on into the future, because it is a really different way of thinking about of treatment. So just my final words is that you've got to work out, living on Olaparib long term is where you fit. I'm not someone who's on chemo. I'm not really someone who's in remission. I'm not cured. I'm this person that's on this long-term, low-level treatment. I look completely normal. I've got all my hair. I don't look unwell, but I know this. I'm still living with the effects of it and living every day with being unsure whether this drug, how long this drug will extend my life for. So in the end, I'd just like to say that I'm delighted to see that there are new ideas out there and that there is some hope. And as individuals, that there's a lot of the science here, but it's really helpful to try and understand as much as possible so that when you read and things and then go and talk to your doctors, that you know what the risks and benefits are of options as they get presented to you, and keep your eyes open for new things as they come out. So if and when I relapse again, I'll be looking for new trials. And thanks to Ovarian Cancer Australia for supporting all of us, giving us opportunities to support each other too. And that's all from me.
Thanks so very much, Kristen. You know that I'm one of your biggest fans. I really enjoy listening to you. I appreciate you coming in and doing this webcast this evening. I'm wondering if we have any questions from our participants, and if so, please type a message in and we can respond to it. I can see that there's another question that's been put up that I imagine I'm going to offer this to Jonathan. Question comes from Vesna. Are there other avenues being explored for ovarian cancer treatment, like systemic RNA delivery? I can't even finish.
Yeah, no, I can see the question. So this is really a question about immune therapy, which is a very exciting area, a new area in cancer treatment, and it's been shown to be really have quite dramatic results in melanoma and in some lung cancers, and now this work is extending into ovarian cancer. But it's at very early stages at the moment. There are clinical trials, and there is a clinical trial, there's been more than one, and there's another one opening, I think, in Australia very soon, looking at these immunotherapy treatments. The types of immunotherapy that are being looked at the moment are with drugs that are actually generally fairly well tolerated. They have to be given by injection, but they're fairly well tolerated, and they are not particularly complex. The question you are posing is a complex scientific question about immunotherapy, and it looks like you've heard about this perhaps from a study in Germany from looking at the question. Those sorts of trials are being thought about around the world, but so far that approach hasn't really been leading very far. But I think where we are hoping that we will see progress in the next 3 or 4 years is with these immune checkpoint inhibitors in ovarian cancer, in the same way that we've seen it in melanoma and lung cancer.
Thank you very much, Jonathan. In light of lack of questions, is there anything Kristen or Jonathan that you would like to finish off with?
Well, I would just like to say thank you, actually, Anne-Marie, again, for inviting me onto this, and to Kristen for really giving such a wonderful talk about your life, coping with the disease with such feeling and such clarity. It was a very moving talk, and I appreciated listening to you. Thank you.
Kristen, is there anything you'd like to say before we sign off?
I just think that if I sort of I can't think what I was going to say. I think I was just going to say that if in trying to work out, because my head had adjusted to, you know, looking only ahead a fairly short time, but now due to Olaparib, it's possible I'm going to live for quite a lot longer. And I don't know, no one knows anything like that. But if I am going to live a long time, I sometimes think, do I want to live like this, with this, you know, reduction in my work capacity and the reduction in my hobbies and interests? Then I think if I were to go off Olaparib, then the question would be moot, because then I wouldn't be living a long time to even worry about that. So it's, I think, a question for all of us who are living with a recurrent ovarian cancer is what do we want to do with the time, and how do we want to get the best value out of the immediate time and not to think too much into the future. And Olaparib's made that time a lot more rubbery. And that's quite interesting, and it's quite challenging. So that's all I've got to add there.
Thank you very much, Kristen. Now look, we've got a couple more questions that's just popped up, which I'm excited about because we do have 3 minutes left. I'm going to pose these questions. Jeanette asks, what do you take for mouth sores?
So I'm not sure whether that relates to chemotherapy or Olaparib. It's not particularly common with Olaparib, but it can occur. So I think it's difficult to know how to answer that depending on what it relates to. But there are a number of medicines, I'm not sure whether the names are the same in Australia as they are in England, for dealing with the symptoms, such as Diflam mouthwashes and Corsidil, which is a sort of disinfecting mouthwash. And then if it is associated with Olaparib, then this would be a time to rest, a drug holiday, if you like, for a couple of weeks to allow the mouth to heal. And again, restarting, it may not occur again. But if it does, then that would be an indication to reduce the dose. If it's to do with chemotherapy, then if it's really significant and troublesome, then you might need to have a reduction in the dose of one of the drugs that you're taking.
Thank you. Another question comes from Denise. Hi, Denise. Can you go back onto chemo after being on Olaparib if cancer grows or recurs?
Well, that's a very good and important question, and the answer is yes, you can. We know from the studies that we've done that many patients who go back onto chemotherapy will again have a benefit from chemotherapy. But we looked at that question a little bit earlier in a slightly different way as to how long that chemotherapy effect might last and whether Olaparib might reduce that effect of the chemotherapy, and we don't really know the answer to that. But there are certainly many women who have been on Olaparib for a while. The drug then, for reasons that we don't understand, doesn't work anymore, and they then go back into chemotherapy, and they have a good response to chemotherapy, and sometimes several other lines of chemotherapy that follow after that. So the answer to your question is yes.
Thank you. And there's a comment from Gail. Hi, Gail, who says, fantastic presentation, and that's a beautiful segue to say that we're about to wrap up our webinar. That I'd like to thank Jonathan and Kristen. Heartfelt thanks. Very brilliant, useful information, and we appreciate the investment in time and being here and giving us that information. This webinar webcast will be recorded and has been recorded, and will be made available on the Ovarian Cancer Australia website shortly. Thank you everybody for attending tonight's webcast. I would encourage you to stay online for just a little minute longer and answer some questions. We have a survey. That survey we use to inform our programs and services. That your feedback tells us what content to deliver in different vehicles. So thank you everybody for attending today's webinar, and we'll see you at the next one.